Anyway, so our next speaker is Shishir Maithel, is a surgical oncologist in hepatobiliary and pancreatic disease, scientific director at Emory Liver and Pancreatic Center, and director at the Cass Foundation Research Fellowship for Surgical Oncology.
Thank you and good afternoon. Thank you to the organizers for the kind invitation. Now we're closing out here, but I'll try to make this as pragmatic as possible in line with the title of my talk about global prospective registry for cholangiocarcinoma patients. So before I begin, I would like to acknowledge Dr. Mark Clemens, who's a medical oncologist in Canada, who really, I spent a lot of time with him on the phone and inspired me to think about this in terms of how other ways to do clinical trials. And Dr. Valle touched upon this during his talk in the morning in terms of novel ways to run clinical trials. And Dr. Clemens' name, similarity to the inspiration for this foundation, is not lost upon me. So the reality in terms of clinical trials, if you look across the board, about 3% of patients with cancer are actually enrolled in clinical trials, so we have to do better. So what are some of the traditional challenges? Again, Dr. Valle touched upon this a little bit. You have the written consent process, which can be very long and arduous for patients and just even getting consent forms approved. The ethics board, the cost of almost $26,000 per patient, that may be on the lower side of estimate. Lots of superfluous data collection that we feel like we need to get, but probably don't use a lot of it. Contracts, drug costs, the research coordination cost, all of those, and having physicians engaged in it, and also patients being engaged in it. So there's lots of challenges. And Dr. Clemens actually has been thinking about this for a long time and looking at traditionals, kind of looking at trials with the fresh eyes. And this was the program that Dr. Valle mentioned in the morning called the REACT program, or Rethinking Clinical Trials. And he started this in 2014 and kind of wanted to approach trials in a more pragmatic way, using databases, basically, and web-based databases between collaborating institutions in Canada. And this focused on breast cancer. So first I'm going to go over the breast cancer stuff and see how we can apply that to cholangiocarcinoma. The key with these types of pragmatic collaborations and these databases is that you have to compare standard of care interventions so that they're not ideal for INDs where you're really testing new drugs. And really look at outcomes that are important to patients. They have simple protocols, a simple consent process, which is primarily an oral consent process. So this is kind of his program. If you look at that kind of spoken wheel of all the potential limitations and obstacles to clinical trials, this is how he reacted to it in terms of demonstration of clinical equipoise using surveys and systematic reviews. Instead, he got away with a written consent and created an oral consent process, and I'll go into a little bit of that in detail. Was able to get all of this IRB approved, had a web-based randomization process in the clinic real time. So a patient basically was in front of you, agreed to do it, oral consent, it was documented in the chart, and based on a web program, they were randomized to their arm A or B, and had real-time electronic data management, such as like a REDCap registration, REDCap web-based platform. And so this is the oral consent process, which really kind of removed a lot of the time and the process of the whole written consent process, which can go on for a week, and you give the patient the form, they read it, come back, you do it again, and you have the CRCs go through it with them. And this was something when he introduced this to me. These are his slides here, so I'm just it's an amazingly important process. However, it's interesting that the signed consent form is rarely really informed, even though we call it informed consent. There's a lot of language on there, a lot of words, sometimes 4 pages long. And even when you talk to the lawyers who've actually had cancer, they say, when I had cancer, I was busy squeezing every last drop out of life. They didn't include reading 20 pages of legalese that no one understands anyway. So there's lots of patients in the audience here, and be interested to hear your viewpoints in terms of when you get these long consent forms. So there is actually precedence for this, and this was a New England Journal paper in 2014 that really kind of highlighted this verbal consent model. And just highlighted in red there, basically you can see I commonly use either one of these in patients to control high blood pressure. They are both taken once a day, and they have similar effects, which are blank, 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 but we don't really know which one is better than the other. So there's like a standard verbiage that you can use documented in the chart. And actually, there is precedence for this being to satisfy the informed consent needs. And again, this is being done in Canada and being approved by their regulatory boards. So it does take some effort, but you have to have a champion. You have to basically have those discussions. The word that Dr. Clements used was fights when he spoke with me, but I'll say the discussions with the IRBs. But it is doable to get done. And then basically once you have that done in the clinic, right there's a randomization process that's web-based, and so patients can be randomized right there. And so there's a really streamlined process. And again, this example, this is a different example than Dr. Vallée showed this morning. You're looking at GM-CSF versus antibiotics. This was just duration of a certain medication that's kind of standard of care, but looking at duration of 5, 7 versus 10 days. So very simple, pragmatic trials. And this is, again, the randomization, just a copy of the form that he uses and how they get randomized. And basically, you do this checklist of very, very pragmatic inclusion, exclusion, and criteria, where you really kind of trying to put it in the real world, like real-time clinic, and then you get that done. And so right when you do it, the physician gets an email right away and knows exactly what arm the patient's going to be on. So that's the traditional process there, with all the talks and going back and forth and the paperwork and coming back. And this is the integrated consent model that he does. So this 5-step process became 2 steps. So what has he done with this? If you look at just this one trial where he was basically trying to get about 450 patients, you can see that how quickly he can enroll. He's been able to enroll patients across these six centers that collaborate with him in a relatively short time. And this is an old slide from 2018, but he told me now when I recently spoke with him, probably over 3,000 or 4,000 patients enrolled in such trials using this mechanism. It does require oversight and monitoring, as you would imagine anything, close email communication, ad hoc meetings, virtual monitoring of the databases, all the usual things you would imagine, but the process is actually much more streamlined and a lot more cost-effective. So these are kind of his groups. He's been able to get trainees. It's been a great mentoring opportunity for him. Lots of trainees have been involved in running trials like this. And so the question I asked after speaking with him was, can we replicate this model for cholangiocarcinoma? So we had the 4th Annual Asia-Pacific Cholangiocarcinoma Summit last year, and one of the goals of that was to try to see if we can create, so I always try to think a little bit bigger. So we have a Canadian network, and I wanted to see if we could create a global network for cholangiocarcinoma to run these pragmatic clinical trials. So we had all the stakeholders at play. We found the people who were involved in the databases in all those countries you see listed there. And we had a very nice 2-hour discussion dedicated to this topic only, in terms of the feasibility of entering data in a red cap-based, web-based platform. What is and how would that look in terms of CCF acting as an honest broker and housing the database? What are the data sharing agreements we would need between not only the institutions but the governments as the data from country goes to another country? Would the verbal consent process be something that would be even feasible in Thailand, Korea, Japan? All of these questions that you can see, pragmatic inclusion, IRB, all of those we discussed. And the long story short is it was probably a little bit lofty to think we could do that. The funding to prospectively maintain a database at each institution. So not everyone has the infrastructure or the FTEs at their own institution to kind of keep someone prospectively maintaining a database, entering the data, but not only entering the data once for a patient, but updating it every 3, 4, 6 months. So basically that became a hard stop in terms of the feasibility of doing it. And then also from the global aspect of things, it was going to be very hard from the regulatory standpoint in terms of sharing data. And that was the kind of sentiment that was shared from some of our Asian partner countries. And also the acceptance of a verbal consent process, our Asian colleagues they're like, absolutely no way, there's no way it's going to happen here. So we had to think of plan B. So this is where we want to capitalize on our collaboration with Citizen. Much of, as from the previous speaker, we know CCF has amazing collaborations with lots of industry and companies that are really trying to forward the disease and forward the science. We turned to Citizen as they have this, as again, patients in this room I'm sure know, they have this mechanism of data capturing for each individual patient record. So the beauty of this is, again, it's no cost to the patient or institution. This does take away the the limitation of the infrastructure issues at each institution or the feasibility of doing it at each institution, and almost quote unquote outsources the data acquisition to Citizen. They have a quick turnaround, probably about 2 weeks is what they've been doing, but now it is currently a domestic company only. They're not going international, although they definitely have that on the horizon to move into a global arena. Now, as we know, they do have this tight collaboration with Invitae now, so now we have access to genetic and molecular data as well, but also just from the patient's charts, if patients undergo NGS for their molecular profile, that data will be in the chart, and that data is captured by Citizen. There was an issue of one-time point of data collection. We wanted this to be a real living, breathing document and prospectively maintained. So these are the questions that we came to Citizen to ask them about. How to handle new patients in their subsequent clinical course, and then how do we optimize and streamline the process for patients signing up for Citizen in terms of like bringing it to the clinics and maybe even having iPads there and having brochures and pamphlets. So these are things we're working on right now. We're going to have a brochure and pamphlet that we're going to distribute to all the centers so we can hand them out. We can basically to facilitate the conversation about the advantages of working with Citizen. And then in order to eliminate that potential the potential lack of signing up when the patient goes home and doesn't get on the computer, we'll hopefully have iPads in the clinic so we can do it real time. And hopefully that will optimize the process of signing up. So this really is moving toward a prospective database. So with Conversations, how have we moved since then? We basically created a wish list of all the data fields we would want. So I did this in a multidisciplinary fashion, having med-onc, rad-onc, IR, hepatology, everyone, kind of all the stakeholders at the table. We created a big wish list of data fields, and we've been working with Citizen, kind of saying, okay, which ones do we already collect? Which ones can we add to the field, and which ones are impossible? They just cannot do based on their current infrastructure and their current process. So we have that list now, which is basically all the objective data that we can get from the medical record. They have the ability, they said, to do prospective updating too. Every 3, 4, or 6 months. We can figure out the exact time, but Citizen will do that. So this will become a prospectively maintained database through Citizen. And then eventually, hopefully, to expand to a global service when the company does it. So I think this will become an amazing resource. So where are we now? We're making the brochures, which is pretty much finalized. We're going to try to get some funding to get iPads so we can distribute these to although iPads are pretty cheap, so hopefully every institution can get one, but we can really hopefully institute this process to really optimize patient signing up for Citizen. 2, we'll have the data fields all set now from the objective fields that Citizen will collect. So again, we've really augmented the database that they were collecting now, and we're going to really almost double that, I would say, based on the fields. 3rd, we're going to combine with the registry, the CCF registry, which Reham has been working on, which collects the subjective data that a lot of through surveys and that patients will supply that Citizen is not able to capture. So that collaboration between subjective data and objective data and having the genetic profiling data as well as the Invitae data, this could become a pretty amazing resource. And then hopefully, again, the plan is not for it to be one stagnant document, but it'll become a real-time updated document that we can actually prospectively watch and see. This will lead to lots of, I think, collaborative research studies. Just from a pragmatic standpoint, with the data going to a third party, this will eliminate IRB issues at each institution. It'll eliminate data transfer agreements at each institution because, again, patients are putting their data in a third party, and we're just using the third party database, which is used. So I don't think we're going to have any regulatory or IRB issues at each institutional level. And so the vision is once we have that in place, again, that will lead to studies where we can look at these patients in data, but then really want to replicate what Dr. Clements has done in breast cancer in Canada with cholangiocarcinoma here in the US, and again, hopefully eventually go global as they expand. But to do pragmatic trials, because I think we'll have enough of the data in terms of demographic, diagnosis, treatment, follow-up, and what they've had, and we'll have the basic medical, surgical, radiation, interventional data. We may not have all the nuances of dose and things like that, but we'll have the pragmatic information, And the pragmatic clinical trials would be centered around things like duration of therapy, again, standard of care type therapies, sequencing of therapy, choice of 2 standard of care therapies, like Dr. Violet mentioned in the second line, FOLFOX versus Naluri or something like that. It's not going to be set up for IND trials, because in that setting you will have to need a little bit more nuances of the data. So that is the kind of vision. That's where we are right now. I think we're moving along. I think it will hopefully lead to I'm hoping it'll lead to a rich resource for us to move forward. And again, this is the team. It's a very big effort. These are just a few people that I've been speaking to over the last few months doing this in terms of the CCF team, the team at Citizen, as well as my fellow Dr. Jess Kielsen and my database manager, Miriam Ahmad. And then all of you. This will not happen without all of you. So everyone, patients need to sign up. Practitioners and the teams need to encourage patients and take the time in the clinics to explain the value of this in the clinics and get people to sign up and really put it there. I think this is the easiest thing to do to really build a phenomenal database. So I will stop there at exactly 15 minutes. Excellent. Thank you.